Hello everybody, I'm Radu Isa, lecturer of microbiology and virology, Faculty of Medicine, Tanta University, Egypt. I will talk about COVID-19. Let's know together what happened. On 31st of December 2019, the WHO China office was notified of a cluster of patients with pneumonia of unknown etiology, probably related to Hainan seafood market in Wuhan, Hubei province, China. On the 1st of January 2020, the seafood market was closed. The SARS, MERS, influenza, and avian influenza were ruled out. On the 7th of January 2020 at 9 a.m., Chinese scientists isolated and performed the genetic sequence of 2019 novel COVID. On the 12th of January 2020, the genome sequence of the novel coronavirus was provided to the WHO. On the 13th, 14th, and 15th of January 2020, first cases of COVID reported outside China in Thailand, South Korea, and Japan. Now we have got a causative organism that was named 2019 nCoV. This was the old name, and the new name is SARS-CoV-2, and we have got a disease which is called COVID-19. The number of confirmed cases outside China was 13-fold higher, 37,364 patients, and the affected countries has increased by 3-fold, 113 countries over a period of 2 weeks. On 11 March 2020, WHO tweeted that COVID-19 can be characterized as a pandemic. Unfortunately, we are facing a pandemic right now. As of the 1st of April 2020, confirmed patients 823,626, and this is 40,598. The COVID-19 is the greatest challenge facing the healthcare system all over the world in the modern era. This is Dr. Li Wenliang. He was an ophthalmologist born in 1986, unfortunately died on 7 February 2020 at the age of 33 years. He was among the first persons to report the outbreak and was detained in Wuhan for spreading rumors. Rising doctors and nurses should remember Dr. Li's name for doing the right and brave thing for his community and the world, and should be encouraged to do the same if they are ever in a moment to make that kind of difference in the world. This was the word of Tom, director of the Center for Health Security at Johns Hopkins Bloomberg School of Public Health. Origin and termination of SARS-CoV-2. Coronaviruses earn their name from their characteristic crown-like viral particles that dot their surface. Order Nidovirales, family Coronaviridae, subfamily Orthocoronavirinae, which classifies into 4 genera of CoVs: alpha, beta, delta, and gamma CoV. Alpha and beta CoV are able to infect mammals. Gamma and delta CoV tend to infect birds. Previously, 6 CoVs have been identified as human-susceptible virus with low pathogenicity, cause mild respiratory symptoms similar to a common cold. On November 2002, in Guangdong, China, also, SARS-CoV caused major pandemic in the new millennium and affecting more than 8,000 persons all over the world, with mortality rate about 10%. Later on the summer of 2012, in Jeddah, Saudi Arabia, outbreak of severe respiratory disease affecting more than 800 patients and the mortality rate 35%. SARS and MERS epidemics resulted in increased interest in the coronavirus research. In this graph showed that the research has increased by 1,000-fold since 2002. Virology. The SARS-CoV-2 is a beta coronavirus envelope non-segmented positive sense RNA virus. Two-thirds of coronavirus genome at the 5 terminus encode viral protein involved in transcribing viral RNA and replication, while one-third at the 3 terminus encoded viral structure and group-specific accessory proteins. The major proteins in the coronaviruses are spike, envelope, membrane, nucleocapsid protein. These biomarkers play a central role in diagnosis, understanding the disease pathogenicity profile, and ultimately any options for a vaccine and or direct antiviral treatment targeted to dismantle the viral life cycle. The origin. MERS-CoV, SARS-CoV, and SARS-CoV-2 all originated from bat. Concerning MERS-CoV, the intermediate host was camel, and it is transmitted to the human through close contact with mucus or fluids. While SARS-CoV, the intermediate host was civet cat and transmitted to the human through diet or close contact. Concerning SARS-CoV-2, the intermediate host was pangolin, and with unknown mode of transmission, it is transmitted to the human and reach the human being. Mode of transmission: respiratory droplets of infected personnel resulting from coughing or sneezing, contact, aerosol generated during clinical procedures. Form of transmission: the spread of virus through an object, door handle, doorbell, respirators also play a vital role in spreading the virus. Hidden transmission can occur from a symptomatic patient with or without normal chastity. The live virus was detected in feces, implying that SARS-CoV-2 may be transmitted by fecal route. A small percentage of blood samples had positive PCR test results, suggesting that infections sometimes may be systematic. Two smaller studies reported the presence of SARS-CoV-2 in anal or oral swabs and blood samples, and viral load in throat swab and sputum samples. Only one report in the literature demonstrated the presence of SARS-CoV-2 in the urine specimen of 6.9% of patients. Transmissibility. The R0 value, pronounced R0, is known as the basic reproduction number and can be thought of as the expected number of cases generated directly by one case in a population where all individuals are susceptible to infection. Early epidemiologic studies in the case of COVID-19 estimate an R0 value of 2.2 reached to 2.5. Here's a comparison between H1N1, SARS, COVID-19, Ebola, and MERS, showing that MERS have got the highest R0 value, 2.5 to 7.2. Incubation period ranged from 1 to 14 days, mostly 3 to 7 days. Case with an incubation period of 27 days has been reported by Hubei province local government on February. Case with an incubation period of 19 days was observed in a JAMA study of 5 cases published on February 21. Pathogenesis. SARS-CoV-2 have a specific spike protein 3D structure that is characterized by its strong binding affinity to angiotensin-converting enzyme 2, ACE2 receptor. The human cells that express ACE2 may act as a target cells for the SARS-CoV-2, like heart, ileum, esophagus, urinary bladder, kidney. This may explain the acute kidney injuries occurring in 0.1 to 29% of the patients with COVID-19. Symptoms. COVID-19 patients usually present with fever, 98.6%, fatigue, 69.6%, dry cough, 59.4%, myalgia, 34.8%, dyspnea, 31.2%, diarrhea and nausea, 10.1%. There are 3 major patterns of the clinical course of infection: mild illness with upper respiratory tract presenting symptoms, non-life-threatening pneumonia, severe pneumonia with acute respiratory distress syndrome that begins with mild symptoms for 7 to 8 days and then progress to rapid deterioration, and acute distress syndrome requiring advanced life support. Complications: acute respiratory distress syndrome, arrhythmia, shock, acute kidney injury, acute cardiac injury, liver dysfunction, secondary infection. Predictors of a fatal outcome in COVID 19 cases: age, the presence of underlying disease, the presence of secondary infection, elevated inflammatory indicators in the blood. COVID 19 mortality might be due to virus activated cytokine storm syndrome or fulminant myocarditis. Prognosis: based on the current information, most patients had a good prognosis, while a few patients were in a critical condition, especially the elderly and those with chronic underlying disease. Additionally, more than 100 children were infected, with the youngest being 30 hours after birth. Neonates and elderly need more attention and care due to their immature or weak immune system. Diagnose: common clinical laboratory findings include leukopenia. Lymphopenia is a cardinal feature of COVID 19. Lactate dehydrogenase and creatinine kinase are elevated. Half of patients had abnormal liver function with elevated alanine aminotransferase or aspartate aminotransferase. Most patients had abnormal myocardial zymogram, which show elevation of creatine kinase and lactate dehydrogenase. Most patients showed normal serum level of procalcitonin. Seroactive protein was above the normal range. One third of patients had the elevation of the dimer. The diagnosis of COVID 19 must be confirmed by reverse transcription polymerase chain reaction for respiratory or blood specimen. Chest CT demonstrates typical radiographic feature in almost all COVID 19 patients, including ground glass opacity, multifocal patchy consolidation, and or interstitial changes with a peripheral distribution. Viral nucleic acid test by RT-PCR assay plays a vital role in determining hospitalization and isolation for individual patients. However, its lack of sensitivity, insufficient stability, and relatively long processing time were detrimental to the control of the disease epidemic. The external factors that may affect RT-PCR testing results include sampling operations, specimen sources, upper or lower respiratory tract, sampling time, different period of the disease development, performance of detection kits, so the results of RT-PCR tests must be cautiously interpreted. Compared to RT-PCR, chest CT imaging may be a more reliable, practical, rapid method to diagnose and assess COVID 19, especially in the epidemic area. It is recommended that the criteria of clinical diagnosed case in COVID 19 affected area that are in shortage of RT-PCR testing kits to control the COVID 19 epidemic based on symptoms, exposure history, typical manifestation of chest CT imaging. Prevention. Preventive measures are the current strategy to limit the spread of cases because an epidemic will increase as long as R node is greater than 1. COVID 19 is 2 to 2.5. So control measures must focus on reducing the value to less than 1. Prevention of COVID 19 is in your hand. Wash your hand thoroughly with soap and water. It's very important to wash your hands after coughing, sneezing, when caring for sick, before, during, and after you prepare food, before eating, after toilet use, when hands are visibly dirty, after handling animals or animal waste. You have to cover your mouth and nose with a tissue while coughing or sneezing. Always clean and disinfect frequent touching surfaces. Never touch your face with unclean hands, and never take or touch hands of the sick people. Stay at home and keep your children at home. Avoid unprotected contact with farm or wild animals. Individuals that are immunocompromised should avoid public gathering. Healthcare worker infections. Healthcare workers were infected at high rates during the outbreaks of MERS 18.6% and SARS 21%. Healthcare workers were infected in part through the use of nebulizers, endotracheal suction and intubation, cardiopulmonary resuscitation, nasogastric feeding, and high flow rates of oxygen. The capacity of COVID 19 to infect healthcare workers has been confirmed, although comparison with MERS and SARS cannot yet be made. Reasons for infection of healthcare worker: inadequate personal protection, long-time exposure to large number of infected patients, pressure of treatment, work intensity and lack of rest, shortage of personal protective equipment, inadequate training of infection prevention and control. WHO recommendations for healthcare workers: standard contact and droplet precautions with eye or face protection. Airborne precautions: N95 or FFP3 masks are recommended in cases where the patient is undergoing aerosol generating procedures, such as tracheal intubation, non invasive ventilation, tracheotomy, cardiopulmonary resuscitation, manual ventilation prior to intubation, and bronchoscopy. Management: considering the lack of direct evidence with regard to treatment of COVID 19, recently proposed guidelines have been built largely on the treatment guidelines of SARS-CoV, MERS-CoV, and influenza. Many patients with confirmed novel coronavirus infected pneumonia in the JAMA study received broad spectrum antibiotics. There are weak recommendations for alpha interferon atomization inhalation twice per day, lopinavir, ritonavir protease inhibitor orally twice per day. A recent systemic review showed that lopinavir anti-coronavirus effect was seen mainly in early application, and no significant effect was seen in late application of therapy. At this time, the use of combined antivirals in the treatment of COVID 19 is controversial. There are currently no randomized controlled trials in the human to support their use. In the patient who deteriorate and require ICU level care, treatment should consider non invasive ventilation, mechanical ventilation, or extracorporeal life support if necessary. Looking to the future, the future is unpredictable regarding the pandemic of COVID 19. Its spread and containment will face unprecedented challenges. Challenges to successful vaccine development include incomplete understanding of viral transmission, pathogenesis and immune response, lack of optimal animal challenge models and standardized immunological assays, as well as insufficient sustainable funding. Remdesivir has recently been recognized as promising antiviral drug against a wide array of RNA viruses. Recent in vitro studies conducted on COVID 19 have found that remdesivir and chloroquine inhibit viral infection of cells with low micromolar concentration with a high selectivity index. Finally, all of us must collaborate to fight this together. We can do it. Of course, we can do it. And thank you all for listening. And I'm glad to be with you. I'm Radwa Isa, and I'm pleased to contact me on my email right there. Thank you very much.